Okay, so first of all, thank you very much. And it's really my pleasure to be here. Thank you, Merck, for the invitation. Thank you for this nice opportunity to discuss regarding the different patients population. So my topic will be to try to define patients with the low prognosis patients and also try to identify specific treatment for these patients. So this is my agenda, because I think it's important to try to define the success in IVF. I will try to also move to the definition of low prognosis patients, the management, and also I will present our data regarding the multi-cycle approach through the dual-stim protocol in this patient population, and then some conclusion. So I am a gynecologist. I work in Italy in a big private IVF setting. And so during my presentation, I will try to share with you also my data in terms of different protocol and the different strategies. I think the first point is to understand which is the goal when we manage infertility patients. And for me, the goal is to try to have a baby. And the measure of the success is the cumulative labor rate per intention to treat. This means that number of the baby is the efficacy of the treatment, but also the efficiency of the treatment is really important. And efficiency means how much time I invest to obtain a baby, which is the cost of the treatment, the cost effectiveness of the treatment, which is the risk when I treat patients, and also which is the dropout rate. So all these factors are very important when we manage infertility patients. It's not just to have a baby, but also the efficiency of the treatment is a very important point. So the first point is that the definition of the patients, of the poor prognosis patients, because poor prognosis patients means patients with few eggs. Poor prognosis patients means patients with advanced maternal age. Poor prognosis patients means patients with abnormal karyotype, with severe male factors, or with a monogenic disease. So all these conditions can define patients with a poor prognosis patients. And of course, in these patients, we will have a low success rate. And also in these patients, we need to invest more time to obtain a baby, and also we have a high incidence of dropout rate. So everybody knows that when we increase the number of the eggs, we can increase the cumulative labor rate, and this correlation is very strong. More eggs means more embryo, more baby. But the point is that what can I do in patients with low prognosis patients, for example, with the low ovarian reserve markers? And unfortunately, this is my patients' populations. Here you can see that during my day, I manage patients with a low number of the eggs, and so here you can see, and also patients with advanced maternal age. So in my setting, more than 84% of the patients has more than 35. And so the important point is the number of the eggs, but we need to keep in mind also the competence of the eggs, because here you can see that when we increase the age of the patients, we have less eggs, but also we have less competence. And how do we assess the competence of the oocyte? Look, the blastulation rate decrease with the age. So this is the point. The quantity is important, but also we need to keep in mind the competence. And for me, competence means blastulation rate, and competence means the aneuploid rate. And so we need to keep in mind also this balance, quantitative and qualitative. And again, if you look at my population in my centers, in the majority of the patients, I collect less than 9 oocytes. This means that I have patients with a suboptimal response. Okay, so fortunately, we have the definition in terms to try to identify patients with the poor prognosis patients. The first definition was the Bologna criteria. The Bologna criteria means patients with advanced maternal age and with less than 3 or less than 3 oocytes, and patients with abnormal ovarian reserve markers. So in this patient's population, of course, we will have a low success rate in terms of cumulative pregnancy. And here you can see that if you use different protocol, different gonadotropin, the live birth per intention to treat in Bologna patients will be around 7%. So 7% when you have patients with advanced maternal age with a 3 oocyte. So today we have a new definition to identify patients with a poor prognosis patient. This is thanks to the Poseidon group, because of course the number of the oocytes is an important issue, but also is an important issue the age of the patients. And then another important point is that the ovarian reserve, because we can have patients with a few eggs, but with a normal ovarian reserve markers. For example, Poseidon number 1 and Poseidon number 2. So in these patients, we have a normal ovarian reserve markers, but at the end of the stimulation, we have a few eggs. And the question is why in this patient's group we have few eggs. Different things is that when we have a group of Poseidon 3 and Poseidon 4, because in these patients we will have low antral follicle count, low MH, and so at the end of the stimulation, of course, we will have few eggs. This is an important point because according with the different patients population, we can identify different strategies. And this is the message, because in all Poseidon group, if you are able to increase the number of the eggs, or if you are able to increase the number of the embryo transfer, your cumulative LIBOR rate will increase. Of course, we need to keep in mind the important role of the age, because in Poseidon group 2 and group 4, we still have low success rate when we treat our patients, if you increase the number of the embryo. But if we switch our mind, if we define the success not only for one treatment, but if we define the success up to 6 IVF treatment, here you can see that you can reach a good cumulative LIBOR rate. And so this is what I think we need to start to thinking, not only one cycle, because if we analyze the journey, if we take in consideration up to 6 cycles, in all Poseidon group we can reach a good success rate, also in patients with a few number of the eggs, and also in patients with advanced maternal age. I think one of the most important goal was the new definition of the successful stimulation. Because the stimulation, I think, is important in order to increase the number of the eggs, but we need to correlate how many eggs I need for each single couples in order to obtain a good embryo. And this is, I think, an important statement, because for each single couples, maybe today we can tailor different number of the eggs. What does it mean? If I have young patients, of course, 4 or 5 eggs can be enough to obtain one competent embryo. And for me, competent embryo means blastocyst embryo and euploid embryo. But here you can see that if we increase the number of my patients, theoretically I will need more eggs because I will have lower blastulation rate and higher aneuploidy rate. We published this paper in 2018 after the new definition of the success according with the Poseidon group. But also the age of the woman, the number of the eggs is important, but also is important the sperm, because sperm has an important role in terms to embryo development. And so all these factors must be very clear when we manage infertility patients. I would like to go back regarding the Poseidon number 1, Poseidon number 2, because in these patients, the management must be very specific. And so these patients has a good ovarian reserve markers, but at the end of the stimulation, we will have suboptimal responders. And this can happen in 30% of the cycle. And so the question is why I have this condition? Because maybe I have a genetic variation of the gonadotropin or their receptors, because maybe I used a lower dose of the gonadotropin, because I had that asynchronism of the follicles, because the asynchronism in patients, in this group of the patients can be an important issue. And also in antagonist cycle, we can have an asynchronism. And also maybe because we had some trigger or ovocyte pickup issue. So what can I do in this kind of patients? I need, of course, to try to optimize the ovarian response. And according with the data today, we can see that if you use the recombinant, you have more opportunity to increase the follicle growth of the follicles. In this patient's population, I think we need to discuss regarding the role of the LH, because I think the role of the LH is crucial in this patient's population, because the addition of the LH at the beginning of the cycle or when you start the antagonist is the only way to try to rescue the follicle growth and to try to avoid the suboptimal responders. And also the priming with estradiol. So in this group of the patients, I think in order to avoid the asynchronism of the follicles, it's recommended to use the estradiol priming, for example, the cycle before the treatment, in order to have a synchronization of the follicular waves. At the last, but not the least, the application of the unconventional stimulation. Unconventional stimulation in terms of duostim protocol is something that if you have patients with a suboptimal responder, in this case we have two options. Or we can go further for the treatment, or we can make a second stimulation in the same ovarian cycle. But I will explain later something more. In group 3 and group 4, the discussion is that you can use whatever you want, different gonadotropin, different protocol, but however, you cannot create follicle ex novo, because the gonadotropin can only support the cohort of follicle that you have. And so this is an important information, not only for the doctors, but also for the patients, because this point can impact the cumulative live birth rate. And so I think in poor prognosis patients, the most important point is to define what does mean good stimulation. This is the paper that we published in Italy with the Italian Fertility Society in order to define how can we assess the quality of my stimulation. Because of course the number of the eggs is not the only goal. We need to correlate the number of the eggs according with the antral follicle count. And this indicator is very important, is the late FOI, follicle output rate. So in every single patient, and in particular in poor prognosis patients, theoretically we need to correlate the number of the eggs according with the antral follicle count. This is the only way if you want to assess your stimulation. And if you look at the data coming from a different group and the different study design, the BMI, the starting dose, the ovarian reserve markers will affect the FOI index. So will affect the number of the eggs according with the antral follicle count. But the question is, we can modify the FOI with different kind of the gonadotropin, and this question is still open. According with the evidence that you have, when we compare recombinant and the urinary, of course we cannot improve the quality of the eggs, but we can improve the ovarian response, because many data support that the application of the recombinant gonadotropin when we compare with the urinary has more efficiency in terms of low dose of the gonadotropin, in terms of better recruitment of the follicles, in terms of shorter duration of the stimulation. So this means that apparently the recombinant gonadotropin is able to optimize the ovarian response in this patient's population. The discussion of the LH, I think, is something very important, because the LH activity is the only strategies that we have in our clinical practice when we stimulate our patients. And the LH activity, in particular in patients with advanced maternal age, because everybody knows that in advanced maternal age we have a low level of androgen, can improve the steroidogenesis. The steroidogenesis in patients with LH and FSH deficiency can be rescued with LH activity. And LH activity, why is it so important? Because it can promote the early stage of the follicle growth, because we can improve the follicle recruitment, and of course, in advanced maternal age population, we can improve the ovarian response to the FSH. And so the question is, okay, we cannot produce ex novo follicles, but we can optimize the ovarian response. And this is what it's mandatory for our patients when we manage infertility patients. So we understood that the woman age, the number of the antral follicle count, the ovarian reserve markers, and the sperm are very important point in terms to codify, in terms to analyze the efficacy of the IVF treatment per started cycle. But what if we change the paradigm? Because the IVF efficacy, not only in terms of intention to treat, but in terms of cumulative labor rate per ovarian cycle. Today we know that the folliculogenesis is extremely dynamic. So during one ovarian cycle, we have different follicular waves, or we have a continuous recruitment terrace. But the problem is that we don't know the mechanism behind the follicular waves. And so we know that during one ovarian cycle, we have different follicular waves, but we don't know very well the mechanism. Anyway, this means that you can start at any time of the menstrual cycle. You can start in the early follicular stage, but you can start in the late follicle phase, or you can start in the luteal phase. And we know this information because, for example, in IVF, in fertility setting, in oncology patients, we start randomly. And this is the reason why. Because we have an extremely follicle dynamic. But also, thanks to this information, we know that we can start in the luteal phase, or we can combine two stimulation in one ovarian cycle in specific patients' population. All these approaches are possible because we have a cryopreservation program. The cryopreservation program and the vitrification is the game changer in assisted reproductive technologies. If you have efficiency cryopreservation program, you can increase the cumulative labor rate. If you have an efficiency cryopreservation program, you can start at any time of the menstrual cycle. So in this case, of course, when you use unconventional stimulation, you need to freeze the embryo and then you transfer in subsequent cycle. Thanks to the vitrification, we can improve the cycle segmentation when we have risk for the OHSS. We can also extend the time for the embryo evaluation, and also we can improve the ovocyte banking. So this is just to understand that when we manage infertility patients, and in particular poor prognosis patients, if you have a cryopreservation program, a efficiency cryopreservation program in your setting, can be very useful to identify specific strategies. So this is our protocol when we manage poor prognosis patients. Okay, in these patients, my goal is to try to optimize the number of the cycle in a short time frame. So usually I start with the estradiol priming, with the estradiol valerate 4 milligram, the 21 of the previous cycle, in order to synchronize the cohort of the follicles. And then I start with the gonadotropin. We support the application of the LH activity at the beginning of the cycle. And then we use flexible antagonist protocol. So usually we trigger with agonist. In this case, we trigger with agonist not to avoid the OHSS, of course, but the application of the agonist trigger is because I want to open the door for the second stimulation treatment in the same ovarian cycle. After we do the pickup, we go to blastocyst. This is our policy in all patients' population, also in poor prognosis patients. We go always the cycle, and when we have an indication after 35, we recommend to use the pre-implantation genetic testing in order to individualize the embryo with a high implantation potential. In the meantime, we wait 5 days, and then we restart again with the second stimulation with the same identical protocol. recombinant gonadotropin, flexible antagonist protocol, agonist trigger, and then pickup, and then we cumulate the embryo coming from the first, coming from the second stimulation, just in one ovarian cycle. When we started with the application of the unconventional stimulation, some question I think was really important, which is the competence when we take the ovocyte from unconventional way, which is the fertilization, which is the blastulation rate when we use unconventional stimulation. Is safety for our patients? And when we have the embryo coming from unconventional stimulation, which is the potential of the embryo? So we started with the protocol in 2016. The first publication was infertility sterility. But over the time, we published our experience. Here you can see that when you take the ovocyte from unconventional way in the luteal phase, in the same ovarian cycle, the competence is equal. So no different in terms of fertilization, no different in terms of blastulation rate, no different in terms of the aneuploidy rate. And when we transfer the embryo coming from unconventional stimulation, again, no different in terms of live birth. So this means that when I have a patient in front of me and when I try to suggest to use a double stimulation in the same ovarian cycle, I can see that this is a safety procedure in terms of ovocyte competence. But why I want to use this approach in my patients? Because this is a multi-center study performed in our centers in Italy, thanks to the contribution of the second stimulation in one ovarian cycle, I can increase the possibility to find at least one euploid embryo in my patients. So because if I manage patients with a few number of the eggs, if I manage patients with advanced maternal age, it's not easy to obtain one competent embryo. So thanks to the contribution of the luteal phase in one ovarian cycle, of course, we can able to increase the chance to obtain at least one euploid embryo. But I think one of the most important points coming from this new protocol is that the variability that we have during one ovarian cycle. So everybody knows that there is a variability between one cycle and another cycle. Same medication, same dose, different number of the ovocyte in different cycle. But this is the reason why, because there is a variability. But thanks to the double stimulation, we understood that there is an intracycle variability during different follicular phase. Because here you can see that only 50% of my patients will have the same number of the oocyte between the first and the second stimulation in one ovarian cycle, and only 31% of my patients will have the same number of the embryo. This means that we manage patients with a huge variability, and the variability is more when the ovary reserve is less. The question is also why in the second stimulation sometimes I can collect more ovocyte, because the data are consistent. In the second stimulation, when you use the same type of the medication, the same gonadotropin, you are able to modify the follicle recruitment and the number of the oocyte, because maybe there is some endogenous priming. So the first stimulation maybe can impact the second stimulation in the same ovarian cycle. And this is something very interesting from the basic science, because seems that we can have the first stimulation can stimulate the proliferation of the FSH receptors in the granular cells. We can have something the changing in the microenvironment when we perform a second stimulation after the first. We can increase maybe the sensitivity of the granular cells. And also one important point is the trigger. Because we usually use the agonist trigger only in patients with the risk for the OHSS. But our experience coming from the application of the GnRH agonist in poor prognosis patients is something very interesting, because when we trigger with agonist, we have a LH source, but also we have a small FSH source. And these small FSH cells maybe can induce a downregulation in the expression of the MAH. And this can be the reason why maybe in the second stimulation we can increase the number of the eggs. Many data is coming regarding the application of the unconventional stimulation and in particular the duostim protocol in poor prognosis patients. And the majority of the evidence support that this strategy is useful in terms to increase the number of the oocytes in a short time frame in patients, in poor prognosis patients population. Many protocols you can find in the literature. So our protocol recommend to use a specific gonadotropin, a specific trigger, but of course many other protocol has been published regarding the application of different protocol. This is the reason why recently was published a new protocol, a new double stimulation protocol. The name is BSTEAM. And the protocol is totally different from our protocol. They use recombinant gonadotropin, they use ACG trigger, they use in the first stimulation antagonist and in the second stimulation PPOS, the oral progesterone to block the late surge. And the conclusion of this study was that the duostim there is no any benefit when you use the duostim if you compare duostim versus two conventional stimulation. Unfortunately, the study design is not really good. You can find a very big bias in terms of study design because the control group was two conventional stimulation, but in the first they performed a fresh embryo transfer in a good embryo. They used the different gonadotropin. They used the ACG trigger. This is the reason why we published a letter to human reproduction just in order to codify that our protocol is totally different from this protocol. But this is just to realize that the evidence is coming regarding of the application of the multiple cycle approach. Why? Because one of the most important benefits when you use this approach is the dropout rate. I don't know if you know the dropout rate in poor prognosis patients. We did a retrospective study, this data coming from my centers before the duostim era. So the live birth is 7% in poor prognosis patients according with the Bologna criteria. So 3x patients with advanced maternal age, unfortunately 7% of the live birth. But look at the dropout rate. The dropout rate is amazing, is 60%. So many patients dropped the cycle, and only 35% of the patients came back for the second IVF treatment. So this means that when we manage infertility patients and when we manage poor prognosis patients, the number of the eggs is an important issue, so the efficacy is an important issue, but also the efficiency. We need to analyze which is the dropout rate. This is the reason why the most important benefit when we recommend this kind of the protocol, for example, duostim protocol, is the dropout rate. Thanks to this application, the patients can understand the importance to try to increase the number of the oocytes in a short time frame in order to increase the cumulative chance of the patients. Because if you compare the duostim protocol versus two conventional approach, here you can see again that the majority of the patients stop the treatment when they fail the first embryo transfer. And in this way, we lose patients, we lose time, we lose chance. Because the time is another important issue in these patients. And so, again, we need to keep in mind not only the efficacy of the treatment, but also the efficiency. We need to propose specific strategies for specific patients' population. This is the reason why this group was proposed the duostim in order to reduce the time to obtain one euploid embryo. I think this is the era to try to change our counseling with our patients. In poor prognosis patients, one cycle sometimes is not enough. We need to thinking about the multi-cycle approach. We need to try to explain to our patients that one cycle maybe is not enough, and so we need to identify specific strategies in order to try to improve the success in a short time frame. Of course, if you want to use these strategies, it's mandatory to have an efficiency preservation program, otherwise you will lose chance. It's mandatory to use a correct drugs, a correct starting dose in order to promote the follicle growth. It's important to select the embryo with high implantation potential. We believe that our goal is not to make one embryo transfer. This is the reason why I want to make an embryo transfer only if I have a competent embryo. For me, competent embryo means blastocyst embryo and euploid embryo. And also we need appropriate counseling, because we need to explain to our patient what does mean these strategies. At the beginning of the story, our goal was to identify patients candidate for multi-cycle approach through the dual-stim protocol before the treatment. But now our policy is totally different. We decided to go to the second stimulation according with the embryo that we have after the first. This is the study that we published the last year. So in patients population with the 3 blastocysts, the 3 blastocysts is a lot, but not in this patient's population, because the patient's population in this study was 40. So at the age of 40, the aneuploidy rate will be 50%, 50%. And so 3 blastocysts is a lot, but maybe is not enough, because maybe we will have 1 euploid blastocyst. And the transfer of the euploid blastocyst will reach around 50% of the live birth. So this means that we did a study in order to compare the dual-stim protocol versus 2 conventional approach in patients with the 3 blastocysts. And again, if we compare the 2 different strategies here, you can see that the dual-stim reduce the time between the first and the second pickup. Look, the 18 days between the first and the second. When you use 2 conventional approaches, around 4 or 5 months. We can increase the cumulative live rate. But why? Because we avoided the dropout, because the patients understand that we need more cycle in order to optimize our chance. At the last but not the least is the cost effectiveness, because of course if you compare these strategies or compare with the 2 conventional in our setting, is more cost effectiveness. I think this is the philosophies, the new philosophies that we can use in this patient's population, also in patients with a monogenic disease. Because in patients candidate for PGT-M with a monogenic disease, we need to take in consideration not only the aneuploid risk, but also the impact of the monogenity. And so the point is that maybe 3 blastocysts is not enough, but 5 blastocysts we need to reach in order to obtain at least 1 euploid embryo. So this means that maybe in the future, for each single couples, we need to try to identify how many embryo I need at the end of the first stimulation, and maybe we can open the door to the new protocol, to the second stimulation in 1 cycle in order to optimize the number of the embryo. This is the data coming from my centers. Until December 2022, we performed the 2000 double stimulation protocol. And of course, the age of my patient is 40, unfortunately, 39.8. This is the mean age of my population. You can see that in the second stimulation is consistent. We can collect more eggs, but no different in terms of fertilization, blastulation, and the euploidy rate. So same competence when we take the ovocyte from unconventional stimulation. And no different when we transfer the embryo in terms of clinical pregnancy rate, miscarriage rate, and live birth rate per euploid embryo transfer. This is the reason why the application of the unconventional stimulation and the contribution of the second stimulation in the same ovarian cycle can be an option in patients, in poor prognosis patients. Because I think the personalization is not just to modify the dose of the gonadotropin. The new era of the personalization is to try to select the right gonadotropin, try to optimize the ovarian response, but to try to reach an ideal number of the eggs and an ideal number of the embryo in order to obtain at least one competent embryo. And I believe that the opportunity that we have today in our setting, thanks to the vitrification, opened the door to the new option. For example, the unconventional stimulation through the duo-stim protocol. The data is coming. Of course, in these patients, it's mandatory to have appropriate counseling, because in these patients we need to freeze all the embryo, and we use the PGTA because in my patients' population this can be useful in order to avoid to transfer embryo without any chance to implant. But I think this is something that we need to implement in our setting in order to personalize the IVF treatment. And so thank you very much for your attention.